our way through using the GoToWebinar. So this morning, the content that we've got lined up for you, I've just got a few sort of just updates. It feels like this is a great platform to share any of that with you so that we're all up to date on what's happening. So I'll share those updates, and then we know that obviously the ENT UK and BSO published some guidance this week. So Sue is just going to walk us through the bits that are relevant for audiology and where we're up to with our own guidance. I've got Ed and Jamie down on the agenda here, but there aren't really any specific updates. So I did get some information from Jason, so I'll just quickly share that on a slide. And then we've got a very exciting, we hope it's a very exciting new feature. I'm sure Vic's feeling a little bit nervous, but we've got a poll that we're going to try. And then we're going to hand over to two of our heads of services who are going to share some of their experiences. So if I can just go to the next slide then, please, Sue. And on again. Okay, so just before we go into that, just to mention about the GoToWebinar, the reason that we have changed it, for those of you that didn't hear Sue when she was talking, is that it does allow us to use some of these interactive facilities, such as the poll, for instance, and a quick raise your hand and things like that. So we'll have a go with some of these features today. It does allow us a larger audience, as Sue has already mentioned. And the other big efficiency for us is in the registration. So once you get sent a link, what it means is that you can all auto register, and then you get the reminders and so forth, and all of that is automated. So that relieves a huge burden off Vic in terms of having to individually register people and so on. So we will continue with this platform because of the efficiencies and the extra functionality, and we'll all learn together as we go through about how the chat and the question functions and the raising hands and Love Hearts works. I can't see some of those functions because the different presenter views are separate from the delegate views. Anyway, so we wanted to just let you know what was going on in the world of audiology at the moment. So this coming Friday, those of you that joined us on the last Heads of Services session listened to Gabrielle and Mancad talking about the audiology remote ways of working. So we're following that up with a webinar to help. So that's happening on this Friday at 3 o'clock. And all of the event details are on the website. So log in, click in to register from there. We received some notification this week from the CSO office that they are also holding a webinar, and unfortunately it does overlap with our remote working one. So that's scheduled to happen at 3:30, and the link is being circulated for that as well if you wish to register. So Sue Hill and Angela Douglas will be presenting on that webinar, and we'll be talking about the impact on healthcare science and so forth through this COVID situation. So as a board, we will split up. So some of us will go on to the remote working webinar, some of us will go on to the CSO one. We hope to be able to have recordings of each of those webinars so that we're able to share those anyway for people who are unable to join and share any of the highlights from those. Thank you. Thanks, Sue. So just, one slide too many. So just as a reminder for registration renewal, we have two regulators who currently have renewal windows open. So the RCCP, which is the one for the majority of you. So that is due for renewal now. That window is open. So you need to click your self-declaration form, and then likewise for the HCPC, if there's any of you that hold hearing aid dispenser registration, that will also need to be done, but the clinical scientists have got another year to wait, so then that's fine. Thank you, Sue. We've been approached by this organisation, MechLink, who are basically a public-facing body that want to share information about health and wellbeing to the public on various different healthcare sectors. They've alerted us to the fact that they exist and that they're there, but they hold no audiology information at the moment. So we've passed that across to our Pubs and Comms committee, who will pick up that piece of work, and we would hope that we're able to then start to signpost audiology for the public, as well as updating our own website with a simple public facing message, particularly just about the support that's available in this COVID environment. But I think this is a great opportunity for us to raise the importance of audiology and sensory health. So we'll get the Pubs and Comms committee to pick that up with them, and Laura will lead that. So thank you. Thanks, Sue. And then there's just been a little bit of noise around the Practice Navigator. Those departments who have Practice Navigator, we believe, have all been contacted by Audit Data to say that they will now be continuing the support of that. So some of the Practice Navigator team have moved across to Audit Data and are able to continue to provide that support. And there is a dedicated email and telephone line for Practice Navigator customers. The issue arises that they are no longer able to support any future development, and so the current version of Practice Navigator is only compatible with NOAA 4.4, which means that as you want to move across to the platform of NOAA 4.5, Practice Navigator is no longer compatible. So there are various discussion groups going on, and it was just really to just highlight and make sure that everybody is aware that there are various trusts talking to each other. We have the NHS networks that exist, whether there's any kind of possibility for trusts to join together and look at any way of improving the procurement and costs associated with moving across to audit base from Practice Navigator, or just as a reminder that you can work with NOAA as a standalone, install the manufacturer's modules into the NOAA alone, and then maybe work with your own trust's patient management system. So again, what other solutions are available, and in the sense of wanting to share practice, if any of you have moved into different ways of working with this, we would appreciate you sharing that so that we can update others. Thank you. So I'll hand over to Sue now then, who's just going to walk us through the new guidance. Thanks, Sue.
Okay, hi. So there are actually 3 new guidance documents from ENT UK, all of which that have been released in the last 24 to 36 hours, and all of which have some relevance to us in audiology. So let's see if we can walk through the 3 documents. They've been released by different parts of ENT UK, and I think it's caused some significant confusion, certainly over the last few hours, over yesterday afternoon. So let me try and break them down. Essentially, ENT UK have put a full document out, and it's about a graduated return to all of elective ENT. And the idea is that it's a resumption of elective activity over a staggered and staged period. Because this was a big working group of the diverse subspecialities, essentially what's happened is that each of the specialities have then released a more specific and detailed guidance. So that first bit was in a letter into ENT UK delegates, members, right, wake up. So the first one, the very general guidance, says that they're recommending that procedures can now be restarted when individual units have everything in place and have the capacity to do it. But they're saying it's where clear need is present. So they're still recommending that their members start the triage system so that they look to continue to do remote triage and remote appointments and remote care if they possibly can. But they are saying that it's safe to restart audiometry, tympanometry, ABR, corticals, VNG testing in the presence of intact tympanic membranes, and then posturography, rotational chair, VHIT and VAMPs. In this guidance, and this is, as I say, the main ENT one, they have taken most of the things that are routine ear surgery and put them into a level 4 priority system. So they can see departments will be undertaking priority 3 cases as well over the next few months, but not necessarily anything from that priority 4 cases. So what we have there is a list of the things that the main document says will restart, but there's more detail in the otolaryngology document for us. So let's take a look at that one. This is the one that was talked about in the joint guidance webinar, and this is the one that's used some of our guidance to take back into their document as well. And it's really nice to see the work that we've done quoted and referenced in this guidance. So this one is one that you really should read, and there's a lot of useful information in there. There's a lot of things that back up the guidance that we've had, and there's a lot of things that they're going to restart and things that they feel are quite comfortable to restart. The first thing to say is that there is a quote that talks about the ear canal not being virus bearing. So anything that we're doing in the ear canal isn't at risk of transferring a viral load to us there. So I think that's really helpful to see. And I think it's hopefully helpful to reassure staff and reassure clinicians as they're starting to restart that actually nothing in an intact tympanic membrane in an ear canal is virus bearing. They've added in the symptom that we all expected them to add in quite a while ago, which is around the loss of smell or taste. So these are their criteria for COVID-19 triage questions. They are the national criteria now. And as I say, it's taken quite a long time to get that criteria changed, but it is now including that sudden loss of smell or taste. So they've talked about some specifics around surgery, and they've said that the majority of surgery falls under priority level 4 that can be deferred beyond 3 months. But for some of the audiology specific things, they've said that there are specific cochlear implant situations that should be restarted more rapidly. So children who are prelingually deaf and on the margins of neuroplasticity for their speech and language development should be a priority level 2. A device failure, leaving somebody that's previously had a cochlear implant without hearing, again, a level 2. A removal of an infected implant is moved higher up into a level 1B, and that post-meningitic where we were worried about cochlear ossification is coming into a priority level 2. So they've been quite specific in this document about some of the procedures. They've pushed BAHA into a level 4B. So they have in this pathology guidance, they've split into a 4A and a 4B, saying that 4A should be higher priority than 4B, but these are still the least of the priority levels. And they have popped BAHA into that level 4B, so any bone anchored procedure. They're suggesting that it could be done as a day case under local anaesthesia as well. And some sites I know have done that regularly for a reasonable amount of time now, but they are taking account of the fact that audiology might not be up and running and that assessments and fittings need to be there before they start putting in the BAHA implants. The cochlear implantation has been moved to level 4, and this is for your adults postlingually deaf, but they feel that paediatric cochlear implants should be a slightly higher level of priority to get restarted, in that they shouldn't wait indefinitely. So they are suggesting that all of these should be done before the age of 18 months. Beyond 18 months is a problem, and any delay beyond 18 months is likely to lead to significant problems for the child. So they have moved that a little bit up the priority scale. So this one I know has caused a lot of discussion And a lot of discussion around what do we do with them. So what do we do with children that aren't going to get surgery for Grommet? And this was the management in outpatients would be preferable, but hearing aids should be considered as an alternative to surgery at the present, because they are going to push them into that level 4, which means that they're not going to get restarted anytime soon. So I guess some of the questions for BAA are, do we need to raise a national concern about this? Should we be looking at trying to raise a concern about budgets being changed? Because as we all know, bone conduction products that you might fit as temporary solutions are more expensive than your standard BTEs. Do we want them to change the guidance? And I don't know how much sway we'd have in that, but it might be a comment that we want to make, that they should consider the guidance again. But also, I think there's an opportunity for people to share some information and any resources they might have on the efficacy of hearing instruments and the types of hearing instruments that we might fit in these cases. And obviously, as with all things, if these are sent to Victoria, our pubs and comms exec should be able to promote those to the wider audience so that everybody learns from each other on this one. So those are some questions that we'd like to think about this morning. And then there's a final piece of documentation that was also released by the Association of Paediatric Otolaryngologists, just to add into the mix. Just to say that all of these are linked to your download section of this webinar, so you'll be able to see it. They say that grommets fall into 2 groups, that soon is somebody with a moderate hearing loss and severe infection, or that we have routine ones where there's a mild hearing loss and an infection but no severe infection. And they're saying that elective operating is reintroduced. It might be suitable to consider performing the soon grommets at some stage rather than waiting for that whole time, and pushing them further and further back. So we'll do that one. So those are our kind of questions generally. We'll be able to obviously look at the questions in a moment. It's not easy to see while I'm talking, but we'll be able to look at some answers to those. I'm going to just touch on the microsuction points, because I know it's something that people have raised, and some of the community clinics in particular are asking questions around this. So the otolaryngology guidance says there appears to be no need to have a period to allow the air room to recirculate after microsuction procedures, although cleaning of surfaces will be required. They're saying that in the presence of a dry tympanic membrane perforation, it's reasonable to follow the recommendations for an intact membrane. And they're suggesting that if you look into a wet ear, even if there's no previous history of a perforation, you might want to consider just dry mopping the wet ear to look for a perforation prior to or in place of microsuction for wax removal. So they are still not recommending that we restart wax removal on perforated ears until we have more evidence about that aerosol generating procedure from the middle ear mucosa. So they're confident and they're comfortable that we haven't got an AGP going on when we're microsuctioning or clearing wax in any way from an intact ear. They've added to that with a dry tympanic membrane, they're comfortable as well. But what they're not happy with still is there's a little bit of research that's quite small research studies suggesting that there may be a problem with middle ear mucosa containing AGPs. So they're still not suggesting that that's restarted generally, and they are talking about FFP3 protection for that. So slightly different in here, as I said, about the grommets, but also the other thing you'll find in here is a bit more advice on outpatients and children. Some of this amused me a little bit. So children are more likely to cough and sneeze uncontrollably. Their parents might not be able to control them in the environment, and they're unlikely to be maintaining a 2-metre social distance from others if they're very small children. So the idea being that you may actually want them to wait outside your department in their cars and just be texted to come into their actual appointment time. They're not worried about the children particularly catching COVID, but they are worried about the children transmitting it to other people in the outpatient environment. They've done what we've always suggested and what your infection control have told pretty much all of you, that all non-essential objects should be removed from the waiting areas. Because children are less easy to control, I'm sure many of you parents who've got your children at home full time are probably thinking that's true. They are saying that staff should be really strict with their PPE for the children, because the children might not be. You've got to be aware, though, that some children might be cause distress or anxiety when they're looking at somebody in PPE. And so they are concerned about that. There's a great little post on Facebook this morning that somebody's bought some masks to try and convince the children that they can all play superheroes. So the children wearing a kind of superhero mask is really nice. So we are just thinking about whether we can reduce cross-contamination by keeping them outside, only bringing them in. This one is the only one that talks about giving the room time to ventilate. And this is if a child's been coughing or sneezing and hasn't been able to tolerate the mask. So if they've been running around your examination room coughing and sneezing, you may want to have a separate room, is what they're suggesting, so that you give the room time to ventilate after that potential aerosol has settled everywhere. So that was really the difference in that guidance. We're working on the frequently asked questions from the webinars. They've fallen into 2 or 3 categories, so they've not been particularly difficult to work on. And the joint guidance group are meeting to review this next week, so the 28th of May. If anybody has any suggested changes, I've said I'll take a first stab at looking through, making sure all the links are still appropriate and working, and looking to update in line with that ENT guidance. So if anybody does have anything that they specifically want us to include, exclude, or make clearer, you're really welcome to email me directly. I've put my own email up just because it's a short time and coming up to a bank holiday weekend, and we are going to try and look at this next week. We don't anticipate huge changes from a first glance, but things I'd like some help with, because I can get pragmatic evidence from the Infection Prevention Society, but I can't get very clear guidance and evidence on the carpeted walls. I know they're not carpeted, the fabric walls and carpets in rooms. The pragmatic evidence is that as long as we don't let the children crawl around them or lick them, then we're probably safe. But they are being treated as a managed risk by many departments, and it would just be nice to have some clear documentation that we can perhaps add in as an appendix for people to consider. We of course have those fabric walls and floors for a particular reason in audiology, and I know I've seen quite a few people saying their infection control are talking about covering them with plastic. I don't think that helps us with the acoustic properties. So if anybody's had that conversation and has come down on the side of no, we'll keep these as a managed risk, and they can send me any documentation we could maybe look at and include, be really grateful for that. Okay, we can try and find the questions.
Okay. I don't think there are any at this moment in time, Sue. Oh,
okay, cool.
I don't know, maybe there are, I can't. It looks like there might be something there, but I can't read it. The box is really small.
I know, that's what I'm finding. Sorry, folks, that genuinely the box for questions is really small. Vic's saying it helps if we put it out into another window, but I don't really understand, Vic. You could unmute your microphone and try and help us.
Sorry, Sue, there is a small icon on the right-hand side. If you
well, icon on the right.
Okay, I've got it.
Oh, yeah.
Popped back. Hang on a sec. Okay. Oh, there's quite a lot, so hang on a minute. Skim through the... Are the questions the same as the chat, or is the questions the presenter only? I think the questions just go to the presenter only, but Vic might be able to answer that one.
Yes, questions just come to presenters and organisers, but if you reply to all, everyone can see the answers and the questions.
Okay.
Oh,
Louise is just commenting that she's going to be talking about telehealthcare. So Rob Lowe is asking about the audit data and practice navigator question. So it feels as if there is some work streams there, and somebody posted a comment before as well about joining the audit-based user group that was published in the spring magazine. Anne-Marie asking about leaving a room for an hour, seeing a patient with an active perforation. Does it say anything? I don't think it does in the guide around the amount of time to leave the rooms ventilated, Sue.
no, there is a slight comment in that paediatric guidance. There's not really much of an evidence base for those being aerosol generating with a perforation, and the guidance for audiology is still that we wouldn't see them at the moment, that we would rule them out. Because the evidence just isn't there that we wouldn't need FFP3. So if you were going to go ahead, you would use FFP3, and he's not suggesting that there is a sort of reason to leave the room ventilated for an hour. So there was no referencing on that at all that I could find.
Just some comments and teething issues, getting used to the webinar, but people happy that we've done that. Thanks, Will. Christine Johnson commenting that to highlight that cough reflex is still an unknown risk.
No, it's not. They're saying that there's a very, so that the otology guidance says that, but we have clear information that it isn't an unknown risk. So the appendix that we have from the Infection Prevention Society says that it's not an unknown risk. Just as a sort of side comment to that, they're looking at 54 different procedures. So a researcher called Tricia Greenhouse, who we've invited to conference previously, they have a full list of lots of things that have been considered to be AGP in the past and now aren't, most of them being dental procedures where you're drilling into bone and things like that. They haven't published that research yet, but as I say, we have evidence from the Infection Prevention Society that the cough reflex isn't an unknown risk. It isn't AGP generating.
Yeah. So then there's a little bit of discussion from Adam and Will around some of the budget changes that are already happening, and the options around offering hearing aids and so forth. I don't know whether we just give the microphone to Adam or Will just to expand a little bit more, and that might just give us a bit more of an insight into any potential work streams we need to pick up. I'm not sure who can give the mic. Is that Vic in control?
Oh, hello, am I unmuted now? Can you hear me?
Thanks, Adam. Yeah.
Okay. I might sound a bit odd because I've got a mask on because I'm in clinic as well. It's just about the comments I posted.
Oh, we've lost you, Adam.
Really around the grommets and the activity that I think we do.
I don't know if everybody else is getting Adam intermittently, but I am.
Yeah, I'm only getting an intermittent voice from Adam.
Could we just try Will, Vic, and then we'll follow up with Adam after the conference webinar.
Hi, can you hear me?
Yes, thank
Yeah.
you.
Okay, great. So, I mean, it was just a comment really from our perspective. So I think this is the position nationally at the moment. Certainly what we've been advised, and I was advised that it was the national picture, also coming from NHS England, is that with pretty much immediate effect, all services are moving from a PBR model over to a block funding model for obvious reasons. Really, is that many services aren't going to achieve a great deal through PBR this year, and there will be kind of obviously COVID uplifts provided for those trusts where they've had excessive COVID activity, and I think that creates certainly it's a positive thing in the short term. Otherwise, most of us wouldn't be seeing a great deal of income coming to our services at all. But in the longer term, it creates that challenge, particularly for audiology services, that we're really going to have to kind of argue our corner and fight for the resources within our organisation. I think that's as much as I've got to comment on that.
Right. Okay.
Okay, thanks, Will. Will, just while you've got the microphone, do you want to just add any comments in around the AGP that you've mentioned?
Yeah, so I mean, we've been considering this, and I've had a fair amount of contact because I've been working up on ITU, and so I've had PPE on for kind of the last 5 weeks. And I mean, certainly I guess the feeling around AGPs is very mixed. The ENT team at our place are considering microsuction as an AGP, given the fact that they don't know what they're going to uncover during microsuction, and whether they are going to uncover a perf or not. My concerns, and I know this is referred to in one of the documents, I think it was the ENT UK one, was about obviously the close proximity, in which if you're placing your face literally within a couple of inches of on your kind of nose and mouth, within a couple of inches of somebody else's nose and mouth during something like a caloric procedure, then even just the breathing, but should they cough, I think, as was identified in one of the documents, there is that kind of arguable chance of like lateral spread outside of the mask straight into your face. The same thing is, I guess, the case with the new hole pipe procedure, and as well, when you're kind of taking a patient down pretty much now kind of into your lap and looking at them straight in the face. And for those of us who do it, that you commonly feel their breath in your face. The point that I kind of had, that I'd raised on the chat here, was more so around air calorics, and you can define an AGP as the flow of air over a mucosal membrane, and I don't know that will have been addressed. I've not seen that that's been addressed in any of the documents, but I think the documents are there for guidance, and my position on this is that we're there to say, okay, well, for most situations those documents are appropriate, but actually for me, I think if you're going to be doing something that is at such close proximity, where your face is going to be up against somebody's ear, breathing in whatever is generated from that ear for a period of 60 plus seconds, then I think that we have to take a sensible and pragmatic approach, and I would advise that people challenge their infection control teams to using FFP3 masks in those situations.
So you're saying for any ear procedure? So what about impressions?
Well, that's another interesting one. So I mean, again, it depends how you look at that. I mean, perhaps your face isn't there for such a long period of time, but yeah, you could generate a cough reflex. My biggest concern, I guess, is for where you are, I'd say, placing your face very close up, looking into somebody's ear, whether that's using a kind of conventional caloric procedure, or whether you're using the air caloric procedures, but you are in very kind of close proximity there. And if you're blowing air into somebody's ear that's going to be blowing back out again, then I think given that there's not a huge amount of evidence out there about what's known about this, I think that does present a risk, an unknown risk. And you know,
I think
for me,
it does if it's a perforated ear. I think I think it's really clear that in the ear canal we're not getting.
Yeah.
Yeah.
That's
So
what
it's
I put
only
on the
for
chat, so I
perforation.
particularly, but you know, I pop that on the chat as particularly if there are any doubts over it. But as I say, I think, you know, each service has to take, you know, their own approach to this, and you know, there are a number of concerns by staff. I think we go with the guidance where possible, and that's a sensible thing to do. But I think that there may be situations where, you know, as with any guidance, we deviate slightly from that if that's you know, if that's a more risk-averse approach, or you know, that's what we undertake as our own kind of risk assessment. So, you know, that's my position on it within my team, and I guess, you know, individuals as clinicians and, you know, heads of service, you know, own approach on that.
Thank you both. That's great. So thanks for sharing that, Will. And as you say, I think we've always left the guidance is still a guidance document, and it will still come down to your own local infection control teams and your local trust priorities and so forth. So we'll move on now. I've picked up a couple of other comments in the chat that I'll come to just now. The slide that's on your screen, then I'll just present just on behalf of Jason and Ed and so forth. But there is a follow-up meeting scheduled for the 2nd of June, where I believe that we want to just sort of really review the interpretation and use of the guidance and whether there are any updates required from it. So I'm sure that Jason or Ed would be really happy to receive any feedback from you about further scenarios that aren't covered in the guidance that you might want to get some advice from, or omissions, or that certain ways of recommendations of working need to be changed. So I'm sure they'd be happy to receive any of that feedback. So if you can get that to them before the 2nd of June, that would be appreciated. I've written up here on the slide that Adrian Davis and UCL were putting a survey together to understand how the guidance has been interpreted and then what services have been provided. Rosemary has told us in the questions chat there that the survey is completed and ready. So she sent us the link through to there, so you can obviously access it from that questions box, but we'll make sure that we circulate that for you as well. So Vic, I'm going to ask you a question now about the hands up bit, because apparently we can just do a quick hands up who, and Michelle Simi has asked a question about face-to-face paediatric clinics and how many services have restarted face-to-face paediatrics. So if you can all see your hand, then press it if it's a yes. Hope that is the right thing to say, Vic. Help me out if that's not.
No, that's fine. People can just raise their hands if they're in agreement with the question.
So if you have started face-to-face paediatric, we've got 153 people online. Where do we see the result then, Vic?
In the attendees box, so I can see there's 4, 5, 6.
Oh, this one doesn't give us an automatic percentage then.
Just have to look down. So it's about 10.
Gonna get all excited going. So we just have to. So it doesn't look like many then, I guess.
Well, it's more than 10% of attendees, definitely. So.
Okay. Well, I hope that helps you, Michelle, and we'll be looking for other heads of services to share experiences in future webinars around restarting face-to-face as well as the remote services. Okay, so if we can just move on to the next slide then, please, whoever's controlling it. So now, back to the poll slide. That's it, there we go. So this is our other moment of trying some new functionality. So we've just done our hands up, we're going to try the poll. So we have a couple of questions really, because we are very mindful of how BAA can continue to support and what you need. And clearly as services do restart, we're mindful that you'll have quite a demand upon your staff time regarding managing backlogs and so forth. So it was really to try to get a feel for what works for you. So we've got a couple of questions that we would like to get an answer for, so that will help us with our future planning. So Vic, do I hand over to you for this bit?
No, the poll should just be launched now, Karen. So if people can just have a look at the question there and click
And then
the
just
box.
hit the radio button for your reply.
Yeah, please.
Fabulous. So the first question really is just centered around when you think you might be able to allow your teams to take some study leave. And that's, you know, from any time now. So between June and the next 3 months, or do we need to wait sort of outside longer than that, or is it even up to 6 months? So if we can get an answer on that. And then do we know when we can move to the next question?
We'll just give people a
Oh,
couple of
seeing
seconds
all
to
the
vote.
percentages building up. Oh, it's very exciting. It's looking like at the moment it's yeah, 40% are really reaching out to plus 6 months, but it's reasonably equal between that and the 3 to 6 months. And then there is a cohort who are able to do it a little bit earlier within the next 1 to 3 months. And we've only got 59% of the people then, is that right, Vic, that have actually voted yet?
Yep, so far. So we'll just give it another 5 seconds and then we'll close the poll.
All right.
So I'll close it down now.
Okay. Oh, we've not got a second question. Yeah.
No, there's the results from the first one.
Get the results. Oh, I'm like, it's very exciting, isn't it? Sorry, everybody, we're all learning at the same time, but that's a really good tool straight away for us to see. So that's really helpful. And then we'll just go to our second poll question. So this one really just relates to the format. So you've got your study leave, but then when you have that study leave, what would be the best method of delivering support, training, connecting events and so forth? So you can see the list of choices there. And very early on, with just a few people voting, we can see that the webinars are winning at the moment. And I think all of our experience during this coronavirus thing, where everybody has relied very much on the remote platforms and webinar platforms, has become an embedded way of us living. So it's an easier way, it's better for the environment, it's cheaper. So there's lots of win-wins. And that's 62% voting at the moment, that's looking strong. One of the thoughts for us around pre-recorded webinars would be that if you are unable to take study leave at the time of the live presentation, that you could then visit that at your own convenience. And apparently we can also host on this platform pre-recorded webinars, but do a live chat afterwards as well. So we can do a sort of a bit of a blend of those first two options perhaps.
The system doesn't seem to want to let quite a few people vote. So if you do want to, I don't know why, maybe just wrong screens and things at the minute, but if you do want to just give us a quick answer in the Q&As, we'll be able to see that. Greg's saying you need to be full screen to vote. Or have you hidden us behind more interesting things? We've got one vote.
So we're on 72% of people voting so far.
We can tell now if you're attentive or not.
Is that that measure of attentive? I was like, what, how, what does that mean?
It's if you've put another window in front.
Oh, okay.
So if you found something more interesting to do.
Okay. Shall we publish the results there then, Vic?
Yep, sure.
Okay, so as I say, we can see really 77% of people are suggesting the live webinar. So this allows people to have more than one choice, and then 66% are looking at pre-recorded webinars, 24% just a small local event, and then not very many at all for the other two. So, okay. That's a very useful insight for board, so thank you very much. if we can move on to where we were in the presentation, please. Should be up to Jane Bevan now. If you can, Jane Bevan to unmute. So we're going a bit higher up. So there you go. That's it. So Jane very kindly has joined us, and Jane is just going to share some of the experiences that they've got in their service delivering remote tinnitus pathway. So thank you very much, Jane.
Me. Hopefully you can all hear me okay.
We can.
Yes, we
Thanks,
can.
Jane.
Okay, good. Yeah, so thanks for asking me to speak this morning. Just asked me to do sort of like a quick overview really of the remote pathway we're using for our tinnitus patients. The tinnitus appointments were probably the first that we started to look at doing remotely. So really I'm presenting this on behalf of our adult therapies lead, Adam Lloyd, and the rest of the tinnitus working group who've done all the hard work on this. So thank you to them. We're certainly not experts on remote working at all. This pathway has been sort of subject to lots of trial and error. We've been amending it as we've gone along, but I thought it might just be helpful just to give an idea of what we're doing for our tinnitus patients at the moment. So I've kind of just created a quick overview of the pathway on the slide there. So we had obviously quite a few new tinnitus referrals that we had to cancel because of the COVID-19 pandemic. So what we had done with those is to pop them all on a waiting list. So initially we send a pack out to the patient, and I've just sort of put a list on there of what we included in that pack. Including in that was a letter just to explain to them that obviously we weren't able to see them in person, and that we were planning to contact them to arrange some remote assessment. So we left that pack with them for a week or two, and then the plan was to phone them back, check they'd received the pack, and then to book them a remote session. They had the choice of whether that session was completed remotely by phone or through a video system, and the one that we are using is the Accurex Fleming platform. That's the only one that our IG team have approved for us to use. We advised them to prepare for their session by having a quiet, comfortable location where they could talk. We explained how the video assessment would work and just let them know that they didn't need to download anything. Most of the people we contacted were happy to schedule a video call. It was about 65% of the patients were happy with a video rather than phone call. I don't know whether that's possibly due to the fact our tinnitus patients are perhaps a slightly younger demographic. There was some reluctance to use the video calls in some cases. Sometimes patients just not keen, or they just didn't have the technology required to take part in that video call. But we've seen a much higher number of people not wanting video calls with other remote working we're doing. So for example, our postal fitting appointments, there's been a lot lower uptake in video calls for that group. But where there was a lack of technology or patients just not keen on the video call, we just arranged a phone appointment. So initially we had actually tried to just sort of miss out that pre-arrangement of a time to call them. We just tried to do a spontaneous calling them to do the tinnitus assessment without pre-arranging a time. But when we did that, none of the patients were actually willing to use the video system at all. So when they didn't have notice about that appointment, they weren't keen to use the video system. We also tried sending them a text message to say that we would contact them within an hour for a video assessment, but that wasn't successful either. So therefore we kind of built in this pre-arrangement phone call, and most patients seem to be a lot happier with a video assessment if they had notice of that happening. So the way it works with Accurex Fleming is that on the day of assessment we send the patient an invite directly to their mobile devices, or some cases their email address if they're using a tablet or a laptop. The Accurex system allows you to send an invitation to a mobile phone, but we haven't been able to figure out how to allow it to send invites directly to email address. So we've had to sort of put our own system in place of sort of copying and pasting the link and sending it via NHS mail, which has been a bit complicated. One of the main drawbacks of Accurex Fleming is it doesn't allow the use of captions. I think that was discussed by a few people at the last head of service meeting. So that's something we're looking into. But so far we haven't had any any real problems communicating over the Fleming system, but I would say a lot of the patients that we're talking to at the moment for our tinnitus patients certainly either have normal hearing or mild to moderate hearing loss, so perhaps that's why we haven't had too many difficulties so far. So we've been managing okay without captions, but I think it would be something that would be useful going forward. So in terms of what happens next, so we do the assessment either through the video call or through a phone call. And then I've just put on the slide there what might happen to the patients after that. So some patients are able to be discharged, and so far, out of all the appointments we've completed, we've discharged 49%, so pretty much half of our backlog of patients we've been able to discharge by using this system. So that's obviously quite helpful when you're looking at recovery planning. For the patients that we didn't discharge, we've been either arranging some further remote follow-up to see how they're getting on, or if we feel that there's a particular reason that they do need face-to-face follow-up when that's available, then we've popped them on a different waiting list for that. For some patients that don't have any access to any kind of technology or other ways of listening to sound therapy, then for example, a CD player, then we've also got the option of sending them a sound ball, which we've purchased a few of those to send out. We've only sent 2 of those out so far, and that's out of about 43 assessments that we've completed. And then the other thing that we have done as well is we also have a postal fitting service with remote follow-up for that. So if anybody that we see for the tinnitus assessments has been identified as a potential candidate for a sound generator or hearing aids, then we add those to our postal fitting list, and then they get something posted out and get followed up remotely through that. And so far, about 45% of the patients that we've seen on this tinnitus pathway have had hearing aids posted out to them as part of our postal fitting process.
Can I interrupt and ask a question for somebody? They're just asking about what's happening in terms of hearing tests and otoscopy with this pathway. Are they already completed?
So they are completed already, because at Chester we don't have a direct access tinnitus pathway. All of these patients have been referred to us via ENT. So the hearing testing, otoscopy side of things has already been done. Not necessarily that recently in some cases, and where we've identified that those patients might need a repeat audiogram, then obviously we would add them to our face-to-face appointment list for when that's available. So as I said, we're certainly not experts in using the system. A couple of things that we've thought about is that it would be good to obviously to have the caption system. There are lots of other web chat systems that allow that. It would be nice to be able to receive messages back from the patient, which we're not able to do with AccuRx at the minute. And possibly being able to send the invite out directly to an email address would be helpful as well. And there may be ways within the AccuRx system that we can do that. It might just be that we haven't sort of been able to work that out for ourselves yet. So as I said at the beginning, really, we're certainly not experts. It's just something that we've put together and seems to be working quite well. And certainly in terms of patient feedback, the patients that we've spoken to are very grateful for the ability to be able to complete their tinnitus assessments, even in the current situation, and the fact that we've actually been able to discharge almost half of them without the need to bring them back in at any point has been quite useful from a service point of view as well. So I hope that's okay. Just a very quick overview of what we're doing at the moment.
Sorry, I'm muted. I'm trying to say something to you and I'm muted. We've got a few questions come up in the chat box for you, if that's all right.
Yes, of course.
So with the fitting, are you doing predicted RCDs or previous REM measurements?
In terms of the hearing aid fittings?
Yes.
In terms of the hearing aid fittings, these are just first fit, so we're just using the click and fit protocol at the moment, with a plan to bring them back in for REMS when we're open to. We don't routinely record our ECDs for our adult patients.
Yeah. Then I've got another one. What if ENT have seen them remotely and referred? So if you got ENT working remotely as well, because then they wouldn't have necessarily an audiogram.
No, none of our ENT colleagues are currently doing any routine work, so there isn't any new referrals for tinnitus coming through from ENT at all at the moment.
Oh, so these are just ones that have already been sat on your waiting list.
Yes, that's correct. Yeah, they're just the backlog of patients. We haven't had any ENT referrals for tinnitus since the outpatient services were suspended mid-March.
Somebody's asking if you have an explanation of the hearing aids through video, or you have a video available for them to see.
Yep, so with our postal fitting service, so this is not just for tinnitus patients, this is for all of our first fit patients as well. We send everything out, and then we arrange a video follow-up where we go through everything with them on the video in terms of using the hearing aids, or the phone if that's preferable to the patient, although obviously that's not quite as ideal. We also link them to any video support as well, any pre-recorded video support.
We've got a comment from Louise just to say that they've also been doing both new and old, and discharge rate has been the same as you. So they're doing a couple for the hearing aid fittings or just a white noise generator. And Julie's asking again, with the history sheet, do your patients send it back to you before the appointment? And if they are doing that, how are they doing that?
No, they're not sending it back. It's just gone through. It's just gone through on the phone or through the video call. So we're not asking them to send that back in. We just go through it with them on the phone.
Okay. So I think those are all your questions. I genuinely find it easier to ask you the questions than to get you to read them. So I hope that was okay.
Yeah, no, that's absolutely fine. I'm not sure I'd be able to figure out exactly where I should be reading from, anyways.
No, we're struggling with that too.
Yeah.
And also just to, so thanks, Jane. And just to let you know that on our next Heads of Services on the 4th of June, Deborah Rose will join us from Bury and Rochdale, and she's also going to share some of the remote service pathways that they've developed for tinnitus, vestibular work and paediatrics, along with hopefully some of the face-to-face clinics that they've restarted, just their experiences with that as well. So that will be a nice follow-up as well, with more experiences for us all to learn from.
Thank you. If anybody is using the Accurex Fleming platform themselves and has any sort of insight to share with us about different ways we can use it, then please get in touch with me, because we're always happy to hear from other people using the same system if they've got any tips.
Tina was saying,
and likewise, we would like to just keep updating the resource platform. So Heather and Laura did a great job in putting together in the Heads of Services resources a lot of the remote tools. So again, any top tips for any of that sort of stuff, we can keep adding into our resources for you as well.
Tina was just saying that they're using Accurex and they're talking about a third-party provider for captions. So hopefully that's underway for them there.
Oh, okay, thank you.
To share. Okay, cool.
Okay, so I think now if we can just move to the next slide. We are joined by Louise from Berkshire Healthcare, who's also going to now just talk us through their experiences with hearing aid fittings and telecare. So thank you, Louise.
Have you found your mute button, Louise? Just looking for Louise. There she is. Oh, it should be unmuted.
Okay, hello, can you hear me now?
We
We
can.
can.
Okay, so it wouldn't let me unmute. Have we got the PowerPoint ready, or do I need to share that? Okay, great.
No, it's there for you, and Sue will
Okay.
progress your slides for you. Thank you.
Thank you. So we've been doing remote hearing aid fittings. So if we can go to next slide, please, and telecare. So we've been in discussion about doing telecare now for 2 years with patients. So this, so I'm the adult service lead for hearing and balance. So this is Judget's. It was promoting telecare within our team, and it was part of our annual plan for the department for the last 5 years in developing remote care appointments for our patients, because looking at everything that's happening here and overseas, it really is the direction that I think we need to head in for a lot of our patients. The other thing is we did a simple fit pilot with the Savantos hearing aids, which were really simple hearing aids. There was a lot of research and development in doing that, and we promoted self-care and getting the patients to set up their, to fit their own aids. And we found that actually they managed it with really not very much intervention. So that also kind of gave us insight in how to set up remote telecare, but also do remote hearing aid fittings. So when we chose the present aids that we have, which are the Ambio aids by GN Resound, that was very much in our mind to make sure that we had an aid that was future-proof, that had telecare, that could allow us to do remote work with it, and we made sure that our information governance was compliant with it before we even started fitting those aids. So next slide, please. So we fitted them in, we started fitting the Ambios in September. The ideal would have been to kind of activate the telecare on the aids at that point, but we hadn't had information governance yet to allow us to do that. But patients downloaded the app, they loved it, they really wanted to start us activating the telecare, and some people were saying, I've activated it, why can't I do telecare? So we kind of started in, and ideal was to start in February, March, but of course other things got in the way. We were having issues with book repairs and not enough staff. So that didn't quite happen, but of course COVID came, so we had already had the information governance approval in place by COVID. We just hadn't actually started switching them on. So next slide, please. Great. So we called all our patients and gave them the option of remote fitting. We had a 99% of patients say, yep, this is what we wanted to do. So these were patients on our next appointment waiting list. They were open fits, they were new patients, they were old patients, they were patients with ear molds. And you'll see from the next slides, not just yet, not yet though, that we had about 50 of those on the waiting list. So we talked about how best to set it. We decided to set it in the coupler. For the old patients, the old fitting strategy was used, and we tried to mimic fit similar to their old aid, and also looked at what tubes and domes they had. New patients, we set them to NL2, and we looked at what had been our main open fit sizes, and looked at the hearing loss and basically made an educated guess. And then we posted the tubes out. So we posted generally 2 sizes, say a size 1 and a size 2, with usually semi-open domes or an open dome if it was a very mild loss, the lost hearing aid letters, the APSA booklets. We also, when we rang them up and checked what programs and listening environments, we emailed a remote fitting letter, and that has links to all the YouTube videos from GN Resound, the See to Hear, and the explanation of telecare. And we also made sure we updated our website to show the same information. So next slide, please. So we've now done 50 patients. We've also identified another 28. So we're sending them now to those patients. Most of the other patients have had their hearing aids for about a couple of weeks. We are sending a process questionnaire and a GHAB to check how they're wearing the aids and how the process has worked, but we haven't actually, we decided not to do any phone or video consultations a fortnight or so after, just because Simple Fit Pilot showed us this wasn't needed. Have we had phone calls or telecare requests? We've had very, very few, 5 telecare requests, a couple of phone calls. Some of those are due to the fact that when you're sending out 50 remote hearing aid fittings and doing them one after another, we've accidentally put a left tube on a right ear mold, or a patient having 1 or 2 queries about, can I have a bigger dome? But other than that, we've actually had no issues. If we can go to the next slide, I've included, for those looking later, the actual letter that we send and also our protocol. What we are finding is that it does take a long time. If you're going to do it properly, it's the equivalent to having a patient with you. Will we continue to do it if the questionnaire backs up that the patients are wearing their hearing aids as much as we think they are? Then definitely, without a doubt. The telecare patients are sending us smiley, happy faces. We're getting phone calls saying this is fantastic, thank you so much for the hearing aid. Same with emails. So what we're finding is it's been a really positive experience for the patients and for our clinicians who have set this up. So I'd like to say very much a big thank you to Cara and Ian, who have been our audiologists, who've been doing most of the setup of these aids. That's it from me.
Okay, thank you very much, Louise. Really great insights again. Are there any questions specifically, Sue, that you've spotted for Louise?
Yeah, there are. So hang on a second. I had some. Has anybody looked at this for paediatric patients? Remote fitting for paediatric patients. I know you said you were adults, Louise.
We have done some paediatric patients, yes. There have been a couple where the parents have requested that we do a remote fitting. So one was a new baby that was diagnosed just before COVID. And so far, no, so we did have the audiogram for that, and the parents doing fine, just need new molds. But the mother was hearing impaired anyway, so she was very cognizant of what needed to be done, and the same with the other child. So we haven't done many, but
Okay.
I think the process would work equally as well with children.
And Adam's saying that he's definitely started doing some remote peds as well. So Dev, you might want to reach out to Adam. George, it's just telling us that you are looking to extend this to starting with the young adults first as well. Yeah. And then I had another one, which was, how do you identify which referrals can have a remote fitting?
So essentially what we are looking at, so we're going through our ENT assess list, any of our SOPs referrals, so anyone that has ideally a recent audiogram, so that was on our waiting list or has had an audiogram in the community. If they've had one in the community, ideally we will get them back in for a follow-up and just a quick check to make sure that that is accurate. And so that's it. And the reassessments, I think if the hearing test was less than a year old, we may look at doing that population as well. But essentially it's just been the ENT assessors and the people who had a reassessment, but we're waiting a fitting.
Okay, brilliant. Hang on a second. The questions keep running around. Oh, Georgie says she can jump in if we wanted to with that. Certainly on the paediatric thing, I think. Should we do that?
Mm-hmm. Yeah, let's give Georgie the mic. Yeah.
I have to tell you, Victoria lost all her internet a few minutes ago. So
Judge, it should have the microphone.
Great.
Oh,
Hi.
Charge it, you should be live.
Lovely, thank you. So it was really just to add that what we are doing, and it sort of just encompasses the whole pathway with the discussions we've had this morning. So our ENT are starting, they're doing sort of obviously remote care for patients. We are now going to be looking towards starting doing audiometry support for our ENT colleagues, with the view that we will be doing audiograms, sort of quick, swift ones, and then sending the patients back home, and then the ENT consultants will then continue their remote care. That's probably phase 1 at this stage. So that will allow for all the new referrals. Now, what we've also got for us, we've got a direct GP referral system that we're waiting to come online, and it's sort of been obviously stalled due to COVID. But again, our commissioners and ENT are very keen for us to start doing that. So all direct referrals for paediatric, adult balance, tinnitus, you name it, the whole lot, will be coming direct to us, and then we would do the appropriate sort of MRI pathway process. So for us, it's around getting that initial assessment in, and as Louise has said, what we're trying to do is minimise the contact time, that the face-to-face contact time we have with individuals. So to be able to do that, the clinicians have kindly worked to pull together sort of a pre-visit questionnaires. So then really what we're doing is we're actually doing the physical assessment of that patient where necessary, and then they can have the rest care and support, counselling, whatever is required remotely thereafter. So it's sort of as an overarching theme, that's where we're going with. And certainly at this stage, this has been sort of driven by the teams themselves. And I know that they were, we were all quite reluctant when we first started about telecare, but I think sort of need to must, and we've got to a point where actually everybody seems to be very happy with it. So we actually use One Consultation, which is our platform. And that's been sort of been used in all sorts of guises in different clinical settings, from our IAPT therapy services, mental health care, as well as sort of some of our dietetics and who am I thinking of? MSK and what have you. So it's sort of a good stable platform that we found, and it allows us to have that two-way communication with our patients. And the captioning, Louise, remind me, I think we've got that now as well. So that's where we are. I don't know whether that sort of gives you just an overarching picture that from our perspective, we will be doing face-to-face assessments, but limited time. So it's reducing the number of the time we have contact with the patient. The rest of it will be remote, particularly with the remote fine-tuning aspects, facilities and functionalities we've got with our hearing aid that we're using at the moment.
Okay, thank you very much, Jajit, for sharing that as well. So we're just really close to the end of our webinar session now, but we do have a request. We did a hands up before for face-to-face for paediatric services, and we've got a request for hands up for adult face-to-face services. So if we can all ask you to raise your hand if you are currently undertaking any limited or whatever the level is, but if you're offering face-to-face appointments at all. Not quite sure who did ask that question, but I think thank you all. So it looks like there's a few more hands up for the adults than there was the pediatrics, if I'm right. But still,
There's about 30 people saying yes so far.
okay, thank you. Okay, great. Subik, are there any other questions or anything that we haven't dealt with that have come through?
So Will was just asking about people doing remote fittings using the Bone Akinoticon hearing instrument. So although they haven't got remote care enabled, are you doing like video consults and sending hearing instruments out? Kate's just said yes, they are. with the phone out, lots of information being posted out, and Louise was just clarifying that a lot of needed only one video, without needing a one-to-one video. So, do any patients not engage with remote telecare when already supplied with their hearing aids, i.e. DNA a telecare appointment, is one of the questions. Don't know if we want to be open.
Can I answer?
Yeah.
So the patients have a couple of options. So we do have patients who haven't accessed the remote telecare because they're a bit older and they don't have access to an app, a phone that's appable, or they just don't feel comfortable doing that. And we've had a couple of queries on the phone, but nothing significant. Through the telecare, we've only had 5 requests for any adjustments, but we have given them huge amounts of information. They have got every video that they need in that remote fitting letter, which has been emailed them. They're sent pamphlets, and booklets, etc. So there isn't any reason that they shouldn't be able to manage it. They've got the C2 Hear videos to understand what issues and what's normal as well. So they do seem to be utilising it. And the comments that we're getting back from patients via email is, this is great, this is wonderful, I'm managing my aid well, thank you very much. We really, but until we do the follow-up letter and can validate those patients that haven't got in touch with us to see if they're wearing their aids as much as we think we are, we don't quite know yet. But our Simple Fit pilot definitely showed us that patients, if they were asked to manage by themselves, tended to wear their aids. So
great, thank you very much. And some of the other comments are saying that it really hasn't been an issue with the DNA unless they just haven't physically been able to contact them.
And that's the same with us.
Lower, yeah. So would you like to VRA? Is anybody doing VRA? Zoe is asking. Only for urgent cases. Has anybody got any operational procedures that they could share perhaps around doing VRA? And Claire. So Claire's comment really is about not setting a precedent for the reduction in service and staff. And so are you contacting GPs just to let them know how you're managing services at the moment? Okay, so as I say, we really are at time now. So thank you so much for all your engagement and participation. Our commitment is to continue doing these as regularly as we are currently while they're still useful. And we'll close the webinar there. Thank you very much. And a recording of it will be posted as usual. So thank you all and see you on the 4th of June.